Okay, so you guys can hear me okay? All right, let's go ahead and get started. So today, Dr. Chang and I are going to go through and present some illustrative cases, vascular cases, by by MR as well as by CT. So Dr. Chang, I think he's on his way back here from West Houston, so hopefully he should be here in time for his part. So let's start off with a case. This is a 72-year-old woman who was transferred here from an outside hospital with presentation of acute chest pain and aortic dissection. Her initial cardiac enzymes at the outside hospital were normal. EKG showed sinus tachycardia, and then when she gets here, she undergoes a repeat CTA scan. So this is the scan done here at our institution. And why don't we just take a minute or so and go through these series of axial slices and make note of what you see, because ultimately you're admitting this patient and we need to figure out how we're going to manage this patient and what other services you need to consult, if any. Okay, so everyone get a chance to see that? You want to see it again? We're going to cycle through this one more time. So again, we're axial cuts from the abdomen coming up through the, up to the neck almost. Okay, so some of you, if you've seen this case before, obviously keep your mouth shut. But if you haven't seen this case before, tell me what would you recommend for this person? So would you call the cardiovascular surgeons for aortic surgery? Would you say, let's just put her in the ICU, aggressive blood pressure control, put her on IV heparin, or do you need additional testing? And if so, tell me why. C, so IV heparin. Okay, so one person for, all right, so let's raise your hand. Who says A? Get the cardiac surgeons to get out of bed in the middle of the night. Nobody. You're afraid? Okay, Dr. Nabi wants to wake up his surgical friends. Who says aggressive blood pressure control only? Okay, so we got one person. Who says heparin? One person. Who says additional testing? Okay, so 2, 3 people. So most of the people have actually either asleep or staying quiet, or what's going on? I mean, you gotta commit to something here. So what? Those of you that didn't raise your hand, why are you not raising your hand? Was that okay? Well, Dr. Naga didn't see the pictures, so that's okay. But we're not calling her Dr. Naga anyway. So I think we have no concerns about Dr. Naga's training. So here's a question. Jeff says heparin. Why?
Well, there's a lot of PE.
Okay. So let's go through these images again.
Not gated.
Okay.
I think it was a trick question.
So you're concerned that there's pulmonary embolism, and that's based on the presence of filling defects in the pulmonary arteries as we get up here? Right there, right? Okay. Bilateral, right? You see one on each side. Okay, so you've got pulmonary embolism. Okay. Now, those of you that said medical or blood pressure control, what was your rationale for that? Okay. So you're concerned about a type B aortic dissection. And again, where is the location of that? Yeah, they can't turn these lights up here. Okay, so describe the location of this. Okay, so it's in the arch. Okay, so arch. Okay, so your concern about motion is what? I mean, if it's a flap that's moving around, because most dissection flaps do move around, right? So, because you got to decide if it's a dissection, and Jeff wants to treat with IV heparin, does he like to see lawyers or something? So what, I mean, I guess we've got two different things going on here, right? Okay. And how would the gated imaging help you?
Should be less motion artifacts you can actually see if that's artifact or a true flap in the aorta.
Okay, so your differential right now is dissection, localized dissection versus artifact, right? Anything else in your differential? Okay, so in that case, then you're saying you want another test? Okay, you want to do a gated CT? Yeah, so that would be a gated. So you're saying a retrospectively. So she's already gotten 2 CTs. You want to give her a third, because she had a CT at the outside hospital. She had a CT here. How much contrast do we give with each of these? 100 cc's, right? 120. Yeah. So that's one option. Yes, I agree. So obviously, there's a reason why I'm up here talking. So what was done in this case was they got an MRI, okay? And again, right, I mean, the issue is obviously, right, your question is you've got 2 different things going on, which raises a concern. And on top of that, there was one other thing that was going on now, is that the cardiac enzyme started coming back elevated as well, right? So, yeah, if you look at these images here, you've got really bilateral filling defects, right? And the timing here is not bad. I mean, so, on again, Faisal can chime in, from CT, the issue obviously is you can get filling defects if you've got inadequate opacification. But in this case, this is pretty well timed for the pulmonary artery as well, right? You don't see a lot of mixing throughout the rest of the pulmonary artery. So I think that this looks pretty convincing for pulmonary embolism, right? And right, right.
Why not a TEE and avoid the MRI? Because the pulmonary embolism is now resolved.
Pulmonary embolism is now, oh, you mean the question of a pulmonary embolism is resolved. Right. You've established the presence of pulmonary embolism. Right. So, what do you guys say? Yeah. So if it's in the middle of the night, I would definitely say let's get Dr. Naga in here. No, so I guess one question. Well, so I mean, I guess the one question would be: is TE the best test if your question is about the arch?
He has no problems with the arch, sending the water,
Okay. Was that before? So I mean, certainly TE could have been an option, I suppose. In this case, they elected to do an MRI as opposed to a TE. And John. Yeah, the other CT showed the same thing as well. They show a linear density in the the distal arch in isthmus. Well, so I mean, again, we didn't have the actual CT scan, but we had the report, which just said that there's a localized dissection in the arch and descending or arch and isthmus. We didn't actually have the images, and that's why they just did the repeat imaging here. Okay. Yeah. So Faisal, do you remember this case? Because you were the one rounding on this patient.
remember we went ahead and decided with the MRI because we felt that, okay,
thought we'd just evaluate the aorta in entirety and look for any other, if there was a dissection there, look for any other functional compromise. Was the patient hypotensive or hypertensive? He was in the ICU at this time, but he was not hypotensive. He was hemodynamically stable.
She did not have, Faisal, do you recall any, so no abdominal pain to suggest mesenteric compromise. And her kidneys, I think, her creatinine took a little bit of a bump, I think, right? But she's gotten 2 doses of contrast. So you don't know if it's just due to the contrast or if it's something else. Certainly on this imaging here, you don't see anything to suspect that there's somehow compromised by dissection to the abdominal aorta. So, because this really looks like it's localized primarily around the arch and isthmus area. So here's the MRI, and let me mag it here.
I think Dipan, you'll also touch on the fact that, if there was a concern for speed, there are sequences, Dipan can run where you can get an answer very quickly. You don't need to do the whole 45 minutes.
Right, yeah, I mean, the way you approach it, if a patient's coming in for suspected acute dissection, if we find that there's involvement of the ascending, then we start out with just an initial set of scout images, and I'll show you what those look like in a second here. This right here, notice this is the first 2 sets of images we acquired is this series of dark blood images, which again are axial images going through the chest. And in this case, with this technique, you make the blood appear dark. And this is one image obtained every cardiac cycle. So this is not it's a gated acquisition, so it's acquired in diastole, but it doesn't take multiple cycles to generate one image. So 1 image per cycle, you just sweep through the entire chest. So within 30 seconds, you can have this full coverage of the chest using this dark blood technique so the blood appears black. And then you do that with a second technique, a bright blood technique, where the blood appears bright. And the reason for that is it's beneficial to have differential contrast, because sometimes you can see something better on a dark background, sometimes you see it better on a white background. So that's why these 2 sets of images right here literally would take you on the order of about a minute to acquire. So we can go through this real quick here. And again, these are just straight axial acquisitions. And these are about 5 millimeter thick slices with no gap. And I'll just go from the abdomen up. And you can just take a look at these. And what do you see? Looks like what? Yeah, and now this is a gated acquisition, so this is obtained in diastole. All right, so this is using the bright blood technique. And again, the important thing we do when you do these first 2 scouts, scan closely at the ascending aorta, because obviously if there's an ascending dissection, then we don't want to continue imaging. You quickly get the patient out and get them to the OR. So the ascending aorta, do you see any involvement? All right, this looks pretty good. So again, we see this localized to this one area right there, right, in the distal arch, okay? That's on the bright blood technique, and then we'll also look at the dark blood technique again to get a differential contrast. And then I'm going to show you this now, and again, we're starting from the abdomen and coming up. So on a dark blood image, you'd probably see a little kind of gray band, gray abnormality. Now, it's not projecting that well on that screen there, because on my computer, on my screen, I can actually see it. There's a little abnormality right here, again, kind of in the same location as before. Is there a way, just for a second, we could turn these front lights out? Just for a second. I know for the video, we want to have them on, but just so everybody can see this. And again, you see this on my screen, I can see a little linear density right here that's kind of grayish in appearance. And on the next slice as well, right here, you can kind of see it. I don't know how well yeah, it's still not very bright. That's fine, you can turn lights back on. So yeah, I guess you'll have to take my word. Well, the other thing we can do is also we've got not just axial views, we've also got sagittal views as well. So let's take a look at these. Because again, what you want to see, if you're concerned about an artifact, now it's kind of getting unusual that CT scan outside a CT scan here, the initial axial MRIs show in the same location this abnormality. But again, if you're concerned about an artifact, what you want to do is look at it in multiple different orientations. So here now is a series of sagittal acquisitions. See this thing right here? Again. Okay, so you think it's thrombus now? What's that? Right. So the issue now is that you can get artifacts. It depends on. There's a variety of different reasons that you can get artifacts. Okay. But the thing here now is you're getting the artifact with multiple different imaging orientations, right? Which makes it less and less likely, right? Because if you had an artifact in one orientation, now that's a whole hour talk. We could talk about different MRI artifacts that can occur. Most common causes is if it's a breathing or an arrhythmia problem. Remember, these are not segmented acquisitions, so they're not taking over multiple cycles. These are images taken in real time in the sense that one image is taken instantly within about 200 milliseconds and diastole. Okay, so causative artifacts could be motion, could be breathing, could be arrhythmias. There's also, especially if you're on a 3 Tesla scanner, when you're at the edge of the visual field, you can get an artifact that's due to inhomogeneity in the magnetic field as you get to the periphery. But again, this is on a 1.5 T scanner, so that artifact is much less likely as well. And then let's look at one other orientation, which is now a coronal series of images. And you see it as well, right? So I mean, I think at this point, you got to say there's no way this can be an artifact when you're seeing it on multiple different orientations. Yeah. So there hasn't been a bubble study done yet. So the only testing that's been done is a CT outside, suggested something in the arch, isthmus. CT scan done here, non-gated, showed the same abnormality. Patients got elevated or increasing cardiac enzymes. They've got evidence of pulmonary embolism. And then obviously what Dr. Little's tuned into is the fact that if I try to put all this together, could this actually be emboli that's doing this, in which case it would be an emboli that's caused a pulmonary embolism as well as crossed a PFO, and then now this is actually a thrombus that I'm seeing. And so this actually is a case where, again, if we do a full set of dynamic images, oftentimes things can be a little bit more clear. So again, there's a difference between gated, because those are all gated acquisitions I showed you. They're gated in diastole. You're still picking one point in time versus doing a dynamic image where you're actually seeing the entire cardiac cycle, because sometimes seeing it throughout the entire cycle can help you quite a bit. So here's now just a series of cine images that we're acquiring. So we're seeing the entire cardiac cycle. Yeah. So now I think it's much more clear what you're dealing with is a thrombus that actually looks like it's plugging up the left subclavian right there. All right. So the other interesting things I think in this case were, let me just show you a couple other views here.
See that on the initial CT scan. If you look, there's a filling defect
in the subclavian. Yeah. But the problem then is you don't know if it is it a dissection that's just causing slow, inadequate opacification. Okay, so the other interesting finding on this case is if we look at the delayed enhancement MRI, also, you notice there's a little area of hyperenhancement right there in the septum, consistent with infarction, all right? And so, what's the territory here? This is like an isolated septal type location. So again, this is probably, all of this probably fits with, and also if you look at the CMR, there's certainly an aneurysmal septum. Now, we didn't do a full PFO assessment, that wasn't really, because that takes time to do, but I would bet you this person, and I think by an echo bubble study that was done later, there actually was evidence of a PFO. So here you've got essentially, lower extremity thrombus, which has led to a pulmonary embolism, PFO, which has crossed embolism to go down the coronary, as well as to go into a subclavian and is affecting the arch as well. So I think in this case, the final management for this person then was really just IV heparin. Okay? Any comments on that case? Yeah, you're absolutely right. So there's what's that? There's no what? TE? Yeah, TE never suffers from artifact issues, so that's great. Okay, so here's another case. This is a abdominal MRA, and again, these are 3D volumetric acquisitions, so now I'm just rotating it around because you've obtained a full 3D volume, you can look at it any orientation you want. And I'll pause it for you just so you can see a little bit better. So what do we see here? Who wants to take a stab at this? Okay, so orientation-wise, this is going to be the right, this is going to be the left. Okay, so the right renal, exactly. So what do you have? This kind of beaded appearance, right? When you see that, what does that raise suspicion for? Fibromuscular dysplasia, right? The other thing is, if you'll notice, obviously it tends to affect the renals very commonly, but it can also affect the carotids and the vertebrals, and occasionally you'll also see it affecting the iliacs as well. And if you take a look down here at the external iliac, you can also get an appreciation that there looks like kind of a beaded appearance to that. Let me see if I can play this. Right there, you see that? You see this right here? There's kind of a little beaded appearance to this. So yeah, this is kind of the classic finding that you see with fibromuscular dysplasia. And obviously a person who has an abnormality in this location, you want to make sure you screen other vascular beds as well. Okay, so some of these are just kind of show and tell. Here's another example. What do you see? So this is a arch MRA. And again, this is your innominate, left common carotid, left subclavian. Left common carotid. Okay, so it looks like there's a very, either severe stenosis or an occlusion, as is also the left subclavian, right? But now, yes, the possibility is could there be external compression to this thing versus could this be, stenosis within the vessel? When you see stenoses that are very long like this, does that? Exactly. This is what you worry about and so obviously for a case like this, we're going to go through and look at axial images to make sure there's not some extrinsic mass that's causing compression as well. But in this case, this was actually this is kind of the classic finding you'll see with Takayasu's, where again it affects the great vessels and it causes kind of these long stenoses that can occur, a long smooth circumferential narrowing of the arterial walls, and oftentimes it can lead to aneurysms as well. So it can lead to stenosis. As well as to aneurysms, and again, frequently affecting the arch vessels. Here's an example. This is not one that we're going to see a whole lot here because we're not a trauma center, but this is kind of the classic finding that you see with somebody who comes in having a motor vehicle accident, and this is an aortic transection, right? Where what's happened is the aorta, essentially at the area of the ligamentus arteriosum, has basically been pulled like a shearing injury. That usually occurs from sudden deceleration accident, injury. Okay, so here's another example. Now these, what I'm going to show you here is a series of axial images that are done in the equilibrium phase. So this is not first pass, or this is not an arterial or a venous phase, but actually this is what we call a vibe technique, where we do this about 10 minutes after contrast administration. So you're truly in the equilibrium phase, and this is great for being able to look both at arterial structures as well as venous structures because you have full contrast opacification. So take a look through these, And again, we're starting just below the iliac bifurcation, and then we're coming up towards the diaphragm. And what do you see here? So let's go through this again one more time. Okay, so those are the iliac veins and the iliac arteries that coming together now, right? That's the iliac bifurcation right there. So we're now into the IVC proper. There's the renal vein, the left renal vein that comes in. And then there's the IVC that goes all the way up. And then there's nothing here. So really, yeah, this is a filling defect. So on this technique here, really the predominant thing that's going to cause a filling defect with no contrast uptake is going to be a thrombus, right? Because this is, again, is 10 minutes after most masses. You would expect to have some contrast uptake, and this is what we call a T1 weighted acquisition. You can see this thing has no contrast uptake at all. So this is consistent with really a thrombus in the infrarenal IVC with extension into the right iliac vein. Yes, Faisal.
If you look at the heart, the septum is black.
In the heart, let's see. Yeah, I mean, it's hard to say because remember, this is not a gated acquisition, so it's hard to say too much about the heart. But again, this is, one of the applications obviously is, ultrasound is very good for lower extremity thrombus, but the area that's a blind spot is the pelvic area for ultrasound, and that's where MR and CT are utilized. And the advantages, I think, of MR is that you can do this venous phase imaging, 10 minutes after contrast. So you don't have to worry about mixing or slow flow. Essentially, if there's any blood flow there, contrast will get there eventually. Okay.
You still need the contrast.
Yeah, you need contrast. Yeah.
The blood gets opacified.
Correct. Exactly. Yeah. Yep. Okay. So here's a case now. This 73-year-old guy comes in with a type 3 aortic dissection. All right. And you can see on the cine images here, you see a dissection flap, right? And these are now MRA images, angiograms. So the interest obviously is not so much this area, but the lower extremities. What do you think about the lower extremities in this case? Okay, it's definitely not equal size, you mean? Yeah, so this is the right and this is the left. So basically what you look at here is the superficial femoral arteries and the trifurcation, and this is the infrapopliteal vessels here. On the right side here, right? So you've got a little narrowing here on. Right. So it looks like, so there's kind of a focal stenosis with just kind of diffuse narrowing of this segment here, right?
But on the left leg, is that not, what is that?
This one here? Which one? On this one?
Yeah, like that outer rim you're seeing, is that?
This right here? Yeah.
Like the SFA?
This right here, you mean? Yeah. Okay, so that's a good observation. So this actually, what you're getting is some, this is basically something that's sitting right next to the artery, right? This actually is just some opacification of the vein. All right. So one of the things you always have to, when you're doing this multi-stage acquisition, you're giving contrast. You image up here first, and then that takes about 10 to 15 seconds, and you come down here and you image, and then you come down here and you image. So sometimes you'll get some venous contamination, and that's all that really is there, is just some early venous contamination. So. And again, obviously, the way you would confirm that is you would look at axial reformations and you would see exactly where it goes, and you'd see that's what it is. So I think most of us would look at this and you'd say, well, okay, so maybe there's a little bit of narrowing here, but it doesn't really look like anything major.
Where is the profunda femoris? We don't see.
Yeah, because the profunda, well, so remember the profunda comes off at the very bifurcation of the common femoral, which is outside of this field, right? So the profunda would be somewhere in this area here. We've got a little bit of a gap between these two.
But
Okay.
you're missing, I guess it would be the perineal or posterior tibial.
Yeah, so if you look at the infrapopliteal vessels, yes, so the vessels here, anterior tibial, perineal, posterior tibial. So the perineal is occluded, it looks like, right? But again, I mean, if you see this, you'll see, people with peripheral disease, you're not going to necessarily do anything per se about that, right?
So that on the other side, though, the perineal, is that there is aneurysm?
So you see the origin of the perineal here. Now this again is outside of the vessel, and again this is actually just some venous contamination you're picking up, okay? And the reason actually showing you this is there's nothing really majorly abnormal on these angiographic images here, but the key point I want you to leave with is, again, this is now when we do our equilibrium phase imaging using that T1 weighted vibe acquisition, and it's playing kind of fast. Let me go through it a little bit slowly. But remember, what I showed you before, these are just lumenograms, right? Because this is just an arterial phase, and it's actually designed to suppress all the background tissue, so you just see the artery without seeing a lot of background tissue. So you get a nice, maximum intensity projection. But if you look actually, let me see if I can get this to, let's do this. If I can play through this slowly, what do you see here? Yeah, there's a big, huge popliteal aneurysm, in fact. Right? If you follow the vessel down, but again, it's a big popliteal aneurysm with a lot of thrombus, right? And so luminogram would completely miss this. And so you really need to make sure that you look at all of the images, and that's why as part of an acquisition, we don't just do an arteriogram and that's it. We always get a set of morphologic images which allow us to see the background tissue as well, because oftentimes the picture is very different when you see everything versus just looking at the arterial structures. Okay, so let me, two more cases to show you real quick. So this now is a 50-year-old woman who comes in with acute chest pain. And so this is what we call a time-resolved angio. So if you've got somebody who can't hold their breath, what we can actually do is do basically a series of angiographic images about 3 seconds apart, which allows you to actually see the transit of contrast. You actually see contrast coming into the right heart initially, and you'll see coming to the left atrium, and you'll see eventually coming out into the aorta, and you'll see the aorta filling. So when you look at this, what do you guys think? Okay, so no. Yeah, I can go frame by frame too. So. So we actually do it both ways. So because this is a series of a full three-dimensional volume that's obtained at multiple different time points, you can actually look at it like this, where there's a series of MIPS, so you can see the contrast transit, and then any given location or time interval that you're interested in looking at in more detail, you can take the full 3D volume into the workstation and you can look at it in different orientations. So it allows you the ability to do both. So now if you look, what do you think about the dimensions of the aorta? Is there,
It's narrow and right on the like where the arch comes.
yeah, so
The question is there a fork there?
right, so there's kind of this narrowing in this area here, which is a little bit unusual, right? Because usually the aorta is not this thin, right? Because this, I think, it probably measures about 1.5 to 2 centimeters in size, right?
What's your scale?
There should be a scale. Let me see. Yeah, the scale here. These are 2 centimeter markings. Yeah, and I can actually measure it here even.
Dr. Is this a good study for dissection? Would this also show your flap in terms of dissection?
What did I measure? So I measured about a centimeter, actually. No, because remember, you never want to look at just an angiogram, right? Maximum intensity projection. You want to actually look at raw images, that are thin slices to look for dissection. So I showed you that one first, but let's go through now and we can look at other images, right? Because again, the key for this is not just to look at one image, but look at a series of images. So let's start out with just these initial set of axial images that we acquire, again, using that bright blood technique. Yeah. So how would you describe the abnormality we're seeing? And then this goes down into the abdomen. Let me show you the abdomen real quick as well. Okay, so the question is, some people said thrombus? Okay, so dissection with thrombus in the false lumen. Okay. Now let me show you, again, the same technique using a dark blood acquisition.
So that would be dark.
Right, so moving blood is dark. Moving blood, yes. Was that? Okay, so that's a good question. So now the question is, how do you distinguish an intramural hematoma from a dissection? Right? So one of the things you want to look for is a tear, because if it's a intramural hematoma, there should be no contrast getting into the area outside the true lumen, right? One of the challenges becomes, so we can look at our series of cine images to try to look to see if we can find a tear, right? But the problem with that is if you want to do a series of cine images, because cine images, you're taking over the time dimension as well, so they take longer to acquire, right? So oftentimes, the best acquisitions for that is going to be to do that time-resolved angio that I showed you before, right? Because we're essentially, let me go back to that again. We're injecting contrast, and then we're doing repeated imaging. And you can see now, if you see any contrast getting into the area outside of the lumen, right? So on this, does it look like we see any contrast exiting the lumen? Not really, right? But again, this is a limitation. You can see a timestamp on the bottom. This tells you how much time after we began imaging, right? So this is typically run for 60 seconds to 90 seconds. So you're only seeing, again, if there's any contrast that goes outside of the lumen within the first minute or so. And that's where going back to the equilibrium phase imaging is beneficial. And that's what this is here. Because this is now 10 minutes after contrast administration. And again, with this technique, you're looking to see if there's any contrast outside of the lumen itself. And what do you see? There isn't any, right? Okay. If you go all the way down, all you see is the lumen, which is narrowed, and then you see this dark area outside of it. Now, the question again is, could this be a dissection with a completely thrombosed false lumen, or could this be an IMH? There's a Q presentation. Okay. So this is one of the things that there's no.
But the interesting thing is that it looks like it's extensive. I mean, it started somewhere in the ascending portion, and it's ending way in the descending. So, right? Am I correct?
Yes,
So
that's right.
For an intramural hematoma, that's one hell of an extension. I mean, these suckers usually are kind of localized in the area. So
Yeah.
the one thing that favors dissection is that
The extent of it. Okay.
But we don't see a tear.
Right.
That favors.
Right. Yeah. So this is one of those cases. So there's a couple other findings on here that I'll show you that I think are somewhat of interest as well, which is if you look at the area of the vessel wall itself, see this right here? It looks like there's a little bit of increased signal in that area, right? Again, consistent with what you might see with inflammation of the aortic wall. And that's also one of the findings that we oftentimes will see in the setting of an IMH, where there tends to be more of an inflammatory component than in the setting of a dissection. The other way, I mean, the ultimate way to know if this is an IMH or dissection, I guess two ways. One is if you go into the operating room, right? But now in this case, it looks like, is the ascending affected? Right, the ascending aorta is not affected, right? Looks like it's really just maybe the distal arch and then really all the way down the descending. So this person was treated just medically. And then I guess the ultimate other way to know is if there's resolution, right? Because if it's a dissection, would you expect it to be completely resolved over time versus an IMH, which you may expect to resolve over time? So I'll show you what happened in this case on follow-up imaging. And this is the same patient, I assure you. So the other thing, so this is one of the things is, some of the kind of thinking we used to think that, oh, IMHs tend to be more localized. I mean, as we've seen a lot of these cases, we find that they oftentimes have very extensive involvement. I think a few things that we find that are different, one is obviously there's no contrast uptake within the false lumen if it's an IMH versus a dissection. The other thing is IMHs tend to actually reduce the size of lumen, whereas in dissection, the overall size tends to not be reduced. If anything, it tends to get bigger because the false lumen tends to actually expand in size. And then the other big finding is that with dissection, you don't see complete resolution like you see with IMH. So I think this is kind of an interesting example of where you can see very rapid evolution of these things, right?
So
I mean,
I think everything here is very appropriate, very convincing. But also, at the time of the acute episode, a PDP would have probably come to same conclusion.
Yeah.
In other words, once, let's say, going from the MRA to the PE would have been another appropriate way of doing it. Because in the PE, you would have seen also that there's absolutely no mobility, no flapping, it's just a continuous area of hematoma and distal vessels. So that would have been
right.
that would have
Yeah.
been equally appropriate.
Yeah.
But it's a beautiful demonstration of healing.
Yeah, exactly. I mean, and that's the thing with these IMHs; they can have significant healing. So I think that there really is a big spectrum between dissection versus an IMH. All right, so let me. Dr. Chang is here. So this second scan here was about 2 months later. 2 months later, yeah. I mean, sometimes you see actually fairly quick evolution just pre-discharge, right? In this person, we didn't have a pre-discharge scan. But oftentimes you'll see a significant increase in the lumen size and a reduction in the IMH size over the course of a week in follow-up. So let me, Sumin, you ready or you want a couple minutes? I can show one quick, you ready to go? Okay. I'll show one quick case here. 74-year-old woman with hypertension, prior history of carotid endarterectomy, and a history of coronary disease, who now comes in for a carotid evaluation. So here's your right carotid. And here's your left carotid. And so the question is, how many of you think we have now severe stenosis of just the right carotid? Raise your hand. Okay, severe stenosis of just the left carotid, raise your hand. Okay, bilateral carotid artery stenosis, raise your hand. Okay, and who says neither? Mawash. Why do you say neither, Mawash?
So weird that it's just back into the same position as all the one minute.
But this is the common location where carotid disease occurs, right? You're saying, well, it's right in the proximal internal carotid, but that's where carotid disease occurs. So I mean so two things actually in peripheral vascular disease, even in the lower extremities, you'll notice frequently lesions tend to be bilateral. So oftentimes you'll see a lesion on one side, you'll see it on the other side in the PAD. So maybe it has to do with just the shape of the vessel and the geometry that somehow leads to that. We know for the carotid that the most common location is the proximal internal carotid. So that fact, I think it's hard to make anything. Now, but the one thing I thought you were going to say is, if you look at the right side, right, you see what looks like a, let's go back here, looks like a pretty nice, discrete lesion here, right? Right, which is a nice focal, discrete lesion. If you look at the left side, how do you describe it? It's a, you know, and again, it's hard for me to stop this, so you know, it's hard for you to fully appreciate. But it's not very well defined, right? And the point of this case actually is that it's important that you always go through and look at all of the images. So look at these morphologic images through the neck, and let's see if this will play. And focus in, especially on that left side. Yeah, so there's some external void, right? No, this is just metal artifact. Remember, the person had a prior carotid endarterectomy, so sometimes they put some little clips in there. So this is just metal artifact which is protruding into the vessel, all right? And so that's why, again, is no, you know, common mistake I see people make is that in the interest of speed, they'll just do the angiogram and that's it. So they do contrast injection, do a quick angio, and you're out. But if you don't do all these other morphologic images, you get wrong answers sometimes. So you need to be able to really see the vessel and the background tissue and the vessel wall itself. Okay. That's all I've got for now. Dr. Chang, you ready?
Sure. Okay, this is for our interventional fellows. So this is the old case that I had. So this is 81 years old female with severe AS, referred here in our early days of TAVR program. It came here evaluated already, including cath. So the cardiac catheterization was done here. But so she came here with CT. Okay. I don't know why the picture is not showing. Okay. Okay, so let's forget the question. So, Mawash, you probably know this case. So, Amen, what do you see? So this is MPR images. Oh, sorry. So this is the common iliac, external iliac, and femoral here. Post-cath. Patient who has cath in a hospital south of here in the medical center. Pseudoaneurysm, okay. The stick probably is too low, right? Okay. So what do you do next? This is 3D rendering, so it's very big, right? So this, so nobody probably leave it alone. You probably want to do something. And she has some tenderness in the area. Okay, this is a vascular ultrasound. Have you seen it now? So what do you see, Mawash? What's the sign called? There we go, see? You actually can see, yeah, it's actually, I didn't know that until the vascular tech told me. I said, oh, and I go now and Google, it's real. So you can see the blood flow, very nicely, the Doppler direction, right? Okay, so what do you do? Surgeon, call the surgeon, resect it. Injection trauma, right? So is this something that first year fellow can do, or anybody can do? I'm not sure. I'll ask somebody with experience.
It's really dependent on the size.
It's pretty big, right? So I have no idea what happened to my slides. A bunch of them are missing. Bunch of them are missing. So, apologize. So the idea was to show you the images actually, all the sequence of injecting the thrombin, and eventually I think this was the final result was you can see the spontaneous contrast, thrombin from fibrin formation, and then eventually resolve. Okay, I think I can spend 2 minutes trying to locate the slides, because otherwise I don't think it's right.